Okay, well, thank you for joining my talk. I'm going to talk to you guys about vasopressors and inotropes. I'm Jessie Winter. I'm one of the critical care and emergency medicine pharmacists at University of Cincinnati Medical Center. And I usually work in the medical and surgical intensive care unit when I'm in the ICU. I worked here for about 10 years, and I'm going to talk to you guys about the pharmacology focus and some literature to support vasopressor use and a little bit on inotropes in the ICU. Just to review general hemodynamics that you guys are probably already familiar with. The main point of administration of vasopressors is to increase the mean arterial pressure, which is a component of cardiac output and SVR. A lot of our drugs work on increasing tone or systemic vascular resistance through alpha-1 receptor agonism, but we also have a lot of medications that can currently work on output by either increasing the chronotropy or inotropy of the heart muscle itself. So positive chronotrope would be something that makes you more tachycardic. Something positive inotrope would be something that helps increase contractility. So if you have positive influences on contractility, stroke volume, heart rate, and cardiac output, you will then increase mean arterial pressure, or you can directly increase mean arterial pressure by increasing systemic vascular resistance. So any shock state is where you have a decrease in perfusion. And that decrease in perfusion can be because you don't have enough volume inside of the vessels, like we see a lot with our hypovolemic shocks, either hemorrhagic blood or non-hemorrhagic, something like septic shock, which is sometimes described as a distributive shock, neurogenic shock or anaphylactic. You just have too loose of tone. Obviously, cardiogenic shock, you have decreased perfusion because your cardiac output has been decreased. Here's the equation of life, or the oxygen delivery equation. As you can see here, if you don't have good oxygen delivery, there's either something wrong with hemoglobin delivery, inability to oxygenate, or your cardiac output. With the administration of vasopressors and inotropes, obviously we're working on the cardiac output endpoint, and we're trying to influence cardiac output and thus increasing the MAP. As I mentioned before, a positive inotrope would be something that increases myocardial contractility. Usually that's an influence of increasing intracellular myocardial calcium. Increased chronotropy would be something that increases your heart rate, so it makes your heart beat faster. We're not going to focus a lot on isoproterenol. That's an old drug that we don't use a ton anymore, plus it's very expensive, but it works very similar to Dobutamine, which is our newer drug. For positive chronotropy and inotropy. Those are described as inotropes. And then vasopressors, which will be most of the chunk of what we're talking about today. Those obviously increase the vasoconstriction of arterioles and blood vessels. And usually that's through affecting directly the systemic vascular resistance by increasing the tone of vessels. So we're going to start with a brief receptor review. So there's a picture here if you're more of a picture person, but just going through each one individually. Alpha-1 receptors are located in all of your peripheral vasculature, and this is a primary target for most of your vasopressors. When you agonize or activate or bind those receptors, the end result is an increased systemic vascular resistance, thus increasing your mean arterial pressure, and it causes vasoconstriction. An easy way to remember that is that little alpha sign has two tails. If you were to grab each one of those tails and pull, the hole would get smaller. So vasoconstriction when you agonize that alpha-1 receptor. Beta-1, you have one heart, two lungs. The way it's often taught, beta-1 receptors are in your heart, whereas beta-2 receptors are in your lungs or your bronchioles. They have different mechanisms of action or different effects when they're agonized. Beta-1, mostly in the myocytes, when you agonize those, you get an inotropic effect, meaning contractility goes up. If contractility goes up, then your stroke volume goes up, then you have an increased cardiac output. It's also a positive chronotrope, so you can get increased heart rate. Beta-2, however, is a vasodilator. So most of these receptors, if you think about common drugs that are beta-2 agonists, this would be something like albuterol inhalations. When you inhale beta-2 agonists, you actually get bronchodilation. You also have beta-2 receptors in skeletal muscles. So when you agonize beta-2 receptors, it actually vasodilates those areas. Most of our vasopressors and inotropes are more targeting beta 1 than beta 2 receptors. However, you might get some beta 2 activity. If you think about, in general, the adrenergic response or the fight or flight response, you want to increase blood flow to your skeletal muscles so you can run faster. You want to bronchodilate so you can breathe in more air, and you want to have increased beta 1 activity so that you have increased cardiac output. So it makes a little bit of sense as to why it's an adrenergic receptor. However, beta 2 receptors are often not the direct target when you're thinking about drugs to increase blood pressure and heart rate. Dopamine receptors are similar. We actually give a drug dopamine, and we can hit dopamine receptors with that dopaminergic drug. However, it's often not the target when we're giving vasopressors and inotropes. Dopamine receptors, like you know, are all over the body, in your brain, in your pituitary, in your myocytes, as well as a lot in your renal and mesenteric vasculature beds. And when you agonize these, it actually causes vasodilation and increased blood flow. That's why some old school transplant surgeons or renal docs might talk about using very low doses of dopamine infused to actually increase urine output, something that's called a urinary dose of dopamine. That's not really recommended anymore. And as you can imagine, dopamine is not usually the target when you're giving vasopressors and inotropes. The drug dopamine actually will target alpha 1 and beta 2 receptors at higher doses. And when we're using it, we're usually going after those alpha and beta receptors, not the dopaminergic receptors. Then we have vasopressin receptors. So we have V1A and V1B, sometimes referred to as V2 receptors throughout the body. V2 receptors are in your kidneys, and they have to do with insertion of aquaporin channels that causes free water and sodium reabsorption into the body. So think about antidiuretic hormone for V2 receptors, you have 2 kidneys. However, V1 receptors are actually all over your peripheral vasculature. So when you give high doses of the drug vasopressin, you can target that V1 receptors and it causes mass vasoconstriction. Usually when we're administering vasopressin, we're not targeting the V1 receptors like we historically used to because the vasoconstriction is much. We're targeting the V2 receptors, so that's sodium and water retention, but the overall hemodynamic effect is usually to increase MAP and increase SVR. Then we have phosphodiesterase. So phosphodiesterase is an ACE. It's a enzyme, and it breaks down the conversion of CAMP to AMP, which I'll show you in a little bit. But it's an inhibitor, so you inhibit this enzyme. And this enzyme is usually located, if we're talking about phosphodiesterase 3, it's located in the myocyte. If we're talking about phosphodiesterase 5, then it's located in pulmonary artery vasculature and in genitourinary. Think about like sildenafil and tadalafil. But when you inhibit this enzyme, it basically causes an increase in intracellular calcium. And that increase in intracellular calcium is a direct inotrope. So you get increased cardiac output, but because there is some PDE5 inhibition, you will get lusitropy, or you'll get decreased systemic vascular resistance. So both vasodilates while it increases your cardiac output, which can be advantageous because that decreases the afterload for the heart. This is just
a question here. I know sometimes during codes and other things in the ICU, we talk about calcium as nature's pressor. And it seems like more intracellular calcium is more helpful. Do you know how much does like pushing calcium or giving calcium help clinically from a blood pressure or inotropy standpoint, or both?
Yeah, it is a direct inotrope because some of the mechanisms of beta and alpha agonism is to increase calcium uptake from the serum. So if you have a reason to think that your patient might be overall calcium down because of critical illness, because of bleeding especially, then it's reasonable to administer, at least make sure calcium levels are up to normal. So that the mechanism of vasopressors and inotropes can work better. However, you don't want to overdo it on calcium. Calcium binds to bicarbonate most of the time when you have patients that are severely oxygen down and lactic acidosis. Because of that, then you're also administering concurrent bicarbonate. So you have to be careful because hypercalcemia can precipitate in the blood. So it's not a right or wrong answer, but it's reasonable to make sure calcium stores are increased or on the higher level of normal when you're treating critically ill patients in need of vasopressors and inotropes.
Thanks.
Cool. And this kind of supports that. So these are the different mechanisms of the agonism of each one of these receptors. So if you look at an alpha-1 receptor, remember that in hemodynamic product of that is increased systemic vascular resistance and increased SVR. And as you can see from this mechanism of action, when you agonize the alpha-1 receptor, it starts a cascade through a G-coupled protein receptor through phospholipase C system to increase levels of IP3. And those levels will increase the release of calcium from the sarcoplasmic reticulum inside of the myocyte. That calcium then goes and binds to myosin. It can increase direct contractility, not only for the myocyte itself, but also can cause the increase in vascular tone. When you agonize a beta-1 receptor, then you utilize adenylene cyclase with energy to make CAMP. And CAMP is really advantageous because it helps you increase calcium influx into the cell. And that intracellular calcium can be very helpful. So that, again, would be a prime example why sometimes giving exogenous calcium would help, because you'd have more calcium in the serum to uptake inside of the cell so that you can either increase your SVR or so that you can increase contractility. And then if you were wondering about dopamine, remember I said dopamine, when you're trying to target the receptor, is usually never ever the target, but we actually give exogenous dopamine as a drug. So why do we do that? It's not because we want to hit dopamine receptors. It's usually because dopamine can get transitioned into norepinephrine and epinephrine inside of the body. So if you see dopamine uptake here, the tyrosine hydroxylase will actually change dopamine and break it down, the drug itself, and then it will use dopamine beta hydroxylase to actually turn itself into norepinephrine. So then you can use that norepinephrine to go bind to beta receptors or alpha receptors, and then norepinephrine is further broken down inside of the body through phenylephynolamine and methyltransferase, this PMT, epinephrine. Epinephrine, again, can directly agonize alpha and beta receptors. The administration of exogenous dopamine is kind of like giving, a drug that needs to be metabolized through several steps to hit the same receptors as if you were going to give norepinephrine or epinephrine itself. So receptors in critical illness are different than normal receptors in healthy patients, as are most things in critical illness. We sometimes will see a desensitization of these catecholamine receptors to exogenous vasopressors. And lots of times that's due to a couple different mechanisms. Sometimes because those receptors are highly albumin bound, and patients are using albumin and prealbumin for energy to help resolve their critical illness. Lots of times it can be due to the often presence of lactic acidosis from decreased oxygen delivery or perfusion. And below a certain pH, that pH is arguable what it is. Some people say 0.2-ish. Then your catecholamine receptors are less likely to bind to those drugs. So we can sometimes see decreased vascular response, so we have to use higher and higher doses. Different people have different susceptibility to vasopressors, so it really isn't a one dose fits all. Every patient's a little bit different in the way they respond. That's why max dosing, when we're asked sometimes as pharmacists, what's the max dosing of this norepinephrine? It's hard to tell you. I can give you what the FDA tells me as a max dose, but it's really whenever your patient seems to show that plateau or non-responsiveness. Another important thing to consider about vasopressors is that a lot of them show that there's evidence that larger patients need larger doses. At UCMC, for the limitation of a couple different drugs, we do not do weight-based dosing. We do things like micrograms per minute. So don't be surprised if you have a 40-kilogram patient that goes hypertensive on 10 of Levophed, but then you have a 125-kilogram patient that doesn't touch them. So keep that in mind when you're administering vasopressors and inotropes, weight-based dosing, there is some evidence that shows that's better. So don't be surprised in larger patients with larger volumes of distributions if they might need higher dosing than your normal bear, average bear. All right, gonna jump into vasopressors. So I kind of separated vasopressors out into two buckets. There's the catecholamine vasopressors. So these are drugs that mimic our endogenous catecholamines, and then there's hormonal vasopressors. So norepinephrine or Levophed would be our first and our mainstay as our vasopressor of choice for most shock states. It's naturally, endogenously released from postganglionic adrenergic nerves, and it hits a lot of different receptors, but our main targets as far as vasopressors are for alpha-1 and beta-1 agonism. It is a ratio, so people will quote about 80% alpha-1, 20% beta-1 agonism. Some people say 90-10, but what you need to remember is that it's always going to be in this ratio. So you're going to hit more alpha-1 than beta-1. So you should get more vasoconstriction than you get increased inotropy, chronotropy / cardiac output. But you can see that as a side effect. This is oftentimes advantageous because if you're increasing alpha-1, you're increasing systemic vascular resistance, which is good because you want to increase mean arterial pressure. However, you can also increase afterload. So if you increase the afterload, the extra help from that 20% beta agonism can help your cardiac output overcome the increased afterload. It is a powerful vasoconstrictor used at higher doses, it's important to remember that it's always going to be in that ratios. We do micrograms per minute at UCMC, but remember what I said about weight-based dosing being important, or you might go work at an institution that does weight-based dosing. Usually you'll see something like 0.1 to 0.5, which would be something like 10 to 50 mics per kg per minute in a 100 kilogram patient. Usually, obviously, targeting a goal map around 60 to 65 based on the shock state that you're treating. And side effects of all these depressors are obviously going to include tissue ischemia, which we can see. With norepinephrine, we see less tissue ischemia than some others. It's also less pro-arrhythmic than other vasopressors, but you can see it because you have that beta-1 agonism if it uses it at higher doses. So it's our first line vasopressor for most distributive shocks and fluid refractory hypotension. And I didn't mention that previously, but I do want to take a second just to emphasize, if you're treating a distributive shock where you have displacement of fluid from intravascular to extravascular, it's a fine balance between making sure your patient's quote tank is full and not over resuscitating them, because then that fluid might distribute into places that are not helpful, like around your lungs, and you might get acute respiratory distress syndrome. But you do want to make sure that they're not fluid responsive, so you never want to put vasopressors on a patient before you've given them what's deemed to be a reasonable fluid challenge, which the surviving sepsis, if we're talking about septic shock, defines as somewhere around 25 to 30 mLs per kilogram. I do want to emphasize that when you're increasing the dose of norepinephrine, it's always going to maintain that ratio. So just looking at that graphically, if you increase the dose of norepinephrine, you're consistently going to get higher alpha affinity than beta affinity. Of course, if you're tachycardic with 10 mics per minute of norepinephrine and you go to 20, you might get increased tachycardia, but you should get ratio-wise and higher effect on blood pressure, which is why we like it so much as an agent to focus mainly on mean arterial pressure. When looking at dopamine, as I've kind of alluded to before, we do not usually give this drug to target dopaminergic receptors. Some people describe it as a dose-dependent drug, which is what the chart on the very bottom of this slide shows, with lower doses targeting those dopaminergic receptors where you actually do not get vasoconstriction, but you get vasodilation around coronary renal vasculature. It's controversial whether this should be used or not, because there's not a lot of evidence that says even if it does cause you to have higher urine output, that it has any higher benefit in patients. Whereas medium doses start to hit beta-1 receptors and higher doses start to hit those alpha receptors. So if you were to administer dopamine and your goal was to actually get squeeze or increase systemic vascular resistance, you'd have to hit a lot of beta-1 agonism before you would start to hit alpha-1 agonism. So you get a lot more beta agonism with dopamine than you do with norepinephrine because it's not as preferential for those alpha 1 agonists. It actually hits beta 1 first. So as you can imagine, a side effect from dopamine, a big side effect of it is going to be tachyarrhythmia. Because of those tachyarrhythmia or proarrhythmic side effects, it's not first line anymore for the treatment of septic shock, and it's usually not first line vasopressor or inotrope for any shock state. There's actually articles that have been released with names like DOPAmine, never use it in the ICU, or the bad drug, just because it has a little bit of an unpredictable dose response in patients. So low doses in one patient may be very potent in another. There was some theory that maybe it would be advantageous in cardiogenic shock because it is got more of an inotropic effect than norepinephrine because it has more of a beta 1 effect on it. And it used to be an alternative in septic shock. However, I'll show you the results of the SOAP2 trial, which kind of made dopamine fall a little bit more out of favor. So then just looking at this again, we have to go through beta 1 agonism to get an equal alpha agonist effect, meaning you have to hit a lot of inotropy, chronotropy before you can get increased systemic vascular resistance. Unfortunately, as you increase the dose of dopamine to hit that alpha 1 effect, that beta agonism never goes away. So to get the squeeze you're going after, you're going to have to get substantially larger amount of beta agonism effect. So if you're giving it so that you can increase your mean arterial pressure, you're usually going to get a lot of tachyarrhythmia that come along with it. And we saw that in the release of the SOAP trial. The SOAP trial was the precursor to the SOAP2 trial. It found that the use of dopamine in patients with specifically septic shock was an independent predictor of mortality. So they redid it in the SOAP2 trial, which was basically taking patients that had sepsis, around 1,700 patients, excuse me, all randomized who had septic shock, and they were either going to receive norepinephrine or dopamine as their first-line vasopressor to target a mean arterial pressure of 65. As you can see here, they all had septic shock, but they could have other shock states. So about 17% of them actually had cardiogenic shock in addition to infection. And their primary outcome was 28-day mortality. They found no difference in that mortality outcome, but they did find a much higher incidence of arrhythmias with dopamine, 24% versus 12.4%, but the number needed a harm of 9. So after the SOAP2 trial, the surviving sepsis guidelines removed dopamine as its primary vasopressor of choice and made norepinephrine its vasopressor of choice because of the tachyarrhythmia side effect. Because there had been some dogma and belief in the cardiology realm that dopamine might be advantageous because it was a direct inotrope, they actually looked at that subset of cardiogenic patients and found that even patients that had concurrent cardiogenic shock had an increased mortality when you were to administer dopamine. So dopamine's really kind of fallen out of favor. Now it still is in that ACLS guidelines for non-symptomatic/symptomatic bradycardia because not because of its vasopressor quality, because of its direct inotropy, but just know that it has a low threshold to giving you a higher incidence of tachycardia and cardiac arrhythmia. So how is it recommended to use? Epinephrine is usually our first line choice of vasopressor. This is specifically for septic shock, but it really is usually our first line choice of vasopressor for most hypovolemic, distributive shock states. Dopamine can be considered in patients that are non-responsive to norepinephrine or as an alternative to norepinephrine, but only in patients that have low risks of tachyarrhythmia or have shown to have a low cardiac output. You probably don't want to give it to somebody that's already showing signs and symptoms of having high heart rate or tachyarrhythmia potential. Moving on to epinephrine, brand name Adrendaline. Obviously, epinephrine is just a mimic of our endogenous epinephrine neurotransmitter that we have inside of our body. It has a very high affinity, usually quoted as an equal affinity between beta and alpha receptors. Some people say 50-50. Other experts have described it as a more dose-dependent effect like dopamine, where lower doses you usually have a little bit more effect on beta receptors, and higher doses you have a higher effect on alpha receptors. But once you start to hit both beta and alpha receptors with epinephrine, epinephrine really is not choosy. It goes to either one of those with equal affinity. So unlike norepinephrine and more similar to dopamine, when you administer epinephrine, you'll get an equal effect on beta and alpha agonism. So there's a higher incidence of tachyarrhythmia with epinephrine than there is with norepinephrine. Epinephrine and dopamine have never been directly compared. Obviously, the best evidence for epinephrine would be for ACLS, and we all know the evidence with ACLS and epinephrine isn't that great. Increases maybe time to ROSC, but not longer outcomes. But you can give it during cardiac arrest at high doses, 1 milligram, or infusions. If you'll notice the dosing, we dose it in 1 to 15 or higher mics per minute. Sometimes during a cardiac arrest, I'll have teams asked to put on an epinephrine infusion in the background, but you have to remember that those are dosed in micrograms per minute. So if you actually wanted that patient that was in ACLS, pulseless ACLS, to get something equal to a milligram every 3 to 5 minutes, you'd have to set that at 300, which our pumps would not allow. So if you do have an epinephrine infusion ever running in the background during pulseless arrest, PEA arrest, where you would be administering epinephrine pushes, then I would always recommend administering those on top of the infusion, just a pearl there. But hopefully we are to the point where we are thinking about epinephrine administration during the ICU where somebody has not lost their pulse. If we do decide to administer that, just remember that this drug has a higher pro-rhythmic effect than norepinephrine because of its obvious increase in beta-1 agonism. And as you increase the dose, you get a higher rhythmic potential similar to dopamine. Side effects that this drug is kind of known for is its decreased perfusion to the mesentery and production of lactic acidosis. So you might see a higher incidence of gut ischemia, dead gut, or lactic acidosis, especially when you're using epinephrine at very high doses. Epinephrine is really your first recommended drug to add on. It's usually used as an adjunctive agent in addition to norepinephrine if your patient's showing that they're not responsive, as long as they're showing that their heart rate can tolerate it without being a risk to be pro-rhythmic. It has, when you might see it used as the first line or single agent, might be in a patient with anaphylactic shock. Usually that's at lower doses, trying to target not only those beta-1 receptors, but lots of times those beta-2 receptors because it causes bronchodilation. Think about an EpiPen. Those are lower doses, 0.3 milligrams. If your patient had a good response to epinephrine during PEA arrest and then got ROSC back, then you might consider using it as your first line vasopressor, but usually you'll try to titrate that down or off onto something that has less potent vasoconstriction and pro-rhythmic like norepinephrine. This was an interesting meta-analysis that was done in 2018. A lot of times in our cardiogenic shock patients, we think epinephrine might be an advantageous agent like dopamine because it hits alpha and beta receptors. This looked at 14 different cohorts and it included about 2,500 patients. They were all in cardiogenic shock. They had been treated with inotropes and vasopressors, but they unfortunately excluded post-operative cardiac surgery patients. At least 15% in patients in each study had been treated with epinephrine, either as solo agent or associated with other inotropes and vasopressors. They looked at mortality, both at 28 days and 30 days. And even when they propensity matched for baseline critical illness, they actually showed that epinephrine remained strongly associated with death. I know that we use epinephrine a lot in cardiogenic shock because it has both alpha and beta receptor blockade. I'd love to see a study where it's compared to, DOBUTamine plus norepinephrine, but if you should really be using epinephrine as an adjunctive agent until you can wean it off and let other agents that have decreased side effect profiles like inotropes or norepinephrine or the combination of both on their own. So currently the surviving sepsis guidelines say you can use epinephrine kind of as your second line additive agent to norepinephrine when your patient's shown that they're not responsive to high/max doses of norepinephrine. Remember, it is a beta agonist, so if you're seeing tachyarrhythmias with norepinephrine alone, you might want to be cautious with the addition of epinephrine. The benefit in cardiovascular shock might not be as substantial as we once thought it was based on that meta-analysis. We will see it used prevalently at lower doses in anaphylactic shock, and then sometimes as our immediate additive agent if a patient had a good response to it after PEA ACLS if they got ROSC back. Phenylephrine is our pure alpha agonist, Neo-synephrine. Anesthesia uses this a lot in a very dilute form slash push dose pressors. Just remember, my recommendation about push dose pressors, that should really be to reverse a vasodilation that you caused, because that's a very temporary effect of a drug. So push dose pressor can either come in the form of a very dilute phenylephrine stick, sometimes we call them, or a very dilute epinephrine stick. That should be because we just gave sedatives to do a procedure, that caused immediate vasodilation, or and we need to give them something short acting because we can't give them volume because they're over resuscitated. So you might consider a push dose pressor. It should not be, you don't like your patient that you think might be getting septic, their blood pressure, so I'm going to give them a push dose phenyl stick every 15 minutes, and then when I go home, the patient crumps, or I never give them volume when they needed volume. So just make sure if you're using these dilute forms, AKA push dose pressors, that we're using them around procedural reasons that we induce hypotension, not as a short-term fix to a bigger problem. So that's kind of my diatribe about push dose pressors. But anyway, I got off track. Back to using phenylephrine as an infusion. Phenylephrine as an infusion is attractive mechanistically because it's a pure alpha agonist. So if you have a patient in septic shock that their primary issue is this huge inflammatory response and leaky vessels, then why not give a drug that is 100% alpha agonism or 100% SVR increasing? That can be good in theory. However, when you give it to your patient, like I kind of discussed before, it can increase your afterload. And if your heart is not able to compensate over that increased afterload, you see a reflex bradycardia with the administration of phenylephrine. So that's why it's really not a great agent in cardiogenic shock when your myocardium might already be not as strong as it should be. If you use phenylephrine, I think of it maybe as an additive agent to norepinephrine. If you have a patient that's very pro-arrhythmic, where usually if your patient's not responding to norepinephrine, your second agent would be epi. If you cannot give epinephrine because your patient's already showing you tachyarrhythmias from the small beta effect of norepinephrine, then you might consider phenylephrine as a second additive agent. Or if you have a patient that has high cardiac output, then you might consider it as an agent to target just alpha 1 receptors so that you get that increased squeeze. But you have to be confident that the heart's going to be strong enough to increase over that afterload. It has a high incidence of peripheral and visceral vasoconstriction, so you really want to be careful with digital and tissue ischemia because it's a potent alpha 1 agonist. And the dosing is a little bit different. So when we talk about epinephrine and norepinephrine, we're kind of used to titrating by 5s, 2.5s, maybe even 10s up to a max dose that's under 100. The phenylephrine actually has a higher range. So anywhere from 200 to 300, some institutions go up to 500 mics per minute. So we really should be titrating phenylephrine by 50s. So because we use it less frequently, sometimes I see it added on to patients, and then the team's titrating phenylephrine by 5s. Not going to see as big of an effect. We should probably be increasing it by like 50 increments of micrograms. It is not recommended to be used as a sole agent in septic shock, except in specific circumstances. It's really more of an additive agent like I previously mentioned. If norepinephrine is causing serious arrhythmias on its own, then you might need to switch to something like phenylephrine, but you have to be cautious with the reflex bradycardia. Or if norepinephrine isn't cutting it and you're already having proarrhythmic, proving that your cardiac output is very high, then you can consider adding phenylephrine on. And sometimes you'll see it's used in neurogenic shock. So some types of neurogenic shock, a lot of them do affect cardiac output. So obviously if your cardiac output's low in neurogenic shock, then you don't want to add phenylephrine on. But sometimes you'll see high cardiac output but low SVR associated with spinal cord injury or neurogenic shock. Then you might see a low dose phenylephrine used on those patients. Okay, moving out of catecholamines as a bucket for vasopressors. There's two vasopressors that are targeting hormonal aspects to increase systemic vascular resistance and mean arterial pressure. The first one is actually an agent that we do not have on formulary at UCMC. It's Giapreza as the brand name, or Angiotensin II. So this works through the renin, angiotensin, aldosterone system. So it mimics our endogenous angiotensin II. Just as a reminder, the liver secretes angiotensinogen, which is then turned into angiotensin I by renin that's secreted from your kidneys. And then angiotensin converting enzyme from your lungs then converts angiotensin I into angiotensin II. Angiotensin II inside of the body is a potent hormone that acts directly on blood vessel vasculature to cause direct vasoconstriction. It's one of our body's most potent vasoconstrictors, as you guys know, because usually our target is to inhibit the conversion from 1 to 2. That's what an ACE inhibitor is. This is the ACE inhibitors, arch nemesis. It increases the conversion of angiotensin I to angiotensin II, and it is directly administration of angiotensin II. So not only that will that cause potent vasoconstriction, but it will also actually stimulate aldosterone to be released from your adrenal glands, and that causes free water reabsorption, which can also increase your MAP. So the study that got this approved was just released in the past couple of years. It was the ATHOS 3 trial. It looked at all patients with vasodilatory shock, and they had to have failed adequate volume resuscitation that they defined as at least 25 milliliters per kilogram in the past 24 hours, and they had to be on what they deemed as high-dose vasopressors. High-dose vasopressors could be arguable. It had to be defined as somewhere around 0.2 mg per kg per minute. That's somewhere, around 20 micrograms per minute of norepinephrine in a 100 kilogram patient. And they had to have a MAP between 55 to 70 on that dose of norepinephrine, at least, or norepinephrine equivalents. They excluded a lot of patients that we take care of, especially in the medical intensive care unit, or CVICU. They included acute coronary syndrome. They included Burns patients. They excluded patients with liver failure, dead gut, anybody that was actively bleeding, they excluded. On ECMO, anybody that was receiving stress dose steroids, which lots of times we consider in the treatment earlier on in some patients in septic shock, or had bronchospasm in this trial, so just something to keep in mind. And then they were randomized into 2 treatment groups. So if you were in the angiotensin group, then you got angiotensin II titrated, and the dosing of this drug is interesting. This trial did different dosing than what's FDA approved, but their median dosing turned out to be similar. But for the first 3 hours, they basically allow this higher dose. So FDA approved is actually up to 80 nanograms per kilogram per minute. But then after 3 hours, you have to cut that max dose in half, and you can only go as high as 40 nanograms per kilogram per minute. So the dosing is pretty interesting with this pressor. But I think the theory behind that is trying to increase or bolus the amount of angiotensin that's available inside of the body, but not keep it very high. Because remember, this is a potent vasoconstrictor, versus patients were just able to get extra norepinephrine administered. So the primary outcome of this trial was after 3 hours, after you have this bolus administration of Angio 2, what happened to their pressor requirements. Patients, when they were enrolled, had a median MAP of around 66. They were pretty sick with an Apache 2 score of 28. And then even though they included all vasodilatory shock states, the majority of them were sepsis or potentially sepsis. You can see there, almost 92% of them, were around septic shock. When you look at their outcomes, they did find, not surprisingly, that if you added a pressor on to patients in this disease state, then they use less extra norepinephrine. So there's some critiques of the primary outcome where it showed if you added another pressor onto a patient that was non-responsive to pressors, you could decrease the amount of norepinephrine they needed versus the other group that needed more norepinephrine to equal the Giapreza. So there's some critique of that primary outcome to support its use because it's not surprising. It would be an expected outcome. And not only that, they used the 3-hour mark before they did that dose reduction. If you look at this study closer, which I think Payal is going to give another lecture to you guys about some of the new and emerging treatments for septic shock. She'll talk a little bit more about Giapreza or Angiotensin II, probably in a little better detail than I am here. But after that 3-hour mark, then Giapreza didn't show to have that much more of a benefit on mean arterial pressure over norepinephrine. If you looked at just the cardiovascular subunit of a SOFA score, it showed improvement because that's MAP. But when you looked at the overall SOFA score, which is a scoring system about acuity and mortality risk in the ICU or in general critically ill patients, it was no difference 2 days after they were administered the drug. And then there was no difference in 7 or 28-day mortality. So what this drug really showed us based on this trial was that it can decrease norepinephrine equivalence and it can increase your MAP compared to open label. So because there's no strong data and the sample size was probably too small to detect a difference in morbidity mortality outcomes, we have not adopted it as part of formulary at UCMC. There's little evidence about what it does to patients after 48 hours. So there's just not enough evidence right now to prove its worth. And a lot of institutions either have not adopted it or have adopted it for use in only specific patient populations. You should see an effect within 3 hours to 48 hours. If it doesn't work after that, it should be discontinued. There's also an interesting finding from early studies from this trial. It shows that there's a prothrombotic or risk of thrombosis with angiotensin II administration of around 13% versus 5% in patients that didn't get it. So until we have further studies that kind of clear up that risk for prothrombosis, when you're thinking about angiotensin II in your patients, it's just an alternative vasoconstrictor that uses a hormone. We just don't have a lot of evidence about whether it's any better than norepinephrine versus just different. So that's why we haven't adopted UCMC. It's also very costly. So when we did a cost benefit analysis, it didn't prove to be that beneficial. To have a bag of angiotensin II, the average wholesale price, which is usually less than what it would be like after we administer it or charge it to the patient's chart, is around $1,800 for a bag. Vasopressin is our next hormonal vasopressor. So obviously vasopressin is endogenous antidiuretic hormone. It is stored in our posterior pituitary normally, and we release it when we have either an increased plasma osmolality, so maybe we're dehydrated, or if we have hypotension. And the release of antidiuretic hormone causes us to insert aquaporin channels and reabsorb more free water. If you give vasopressin exogenously at higher doses, then you can be less specific for that effect on free water absorption. And you can target actually vasopressin 1 receptors that are all over your peripheral vasculature. And it causes a very potent vasoconstriction. We used to use vasopressin administration at high doses, but it caused such bad tissue ischemia that it probably isn't as safe. So when we're using vasopressin now, we're not using it at higher doses. We're targeting those V2 receptors in the kidneys to do free water absorption, so we see a lot less side effects with it. So it's an adjunctive therapy, and most of the data with vasopressin, though there is some data in postoperative vasoplasia for cardiac patients, and there's some data with hemorrhagic shock, most of the supportive data are patients with septic shock as an adjunctive agent to norepinephrine. It's dosed at 0.1 to 0.04 units per minute. The VASH trial, which we'll talk about in a second, did 0.03 units per minute. So it's a fixed dose, non-titratable. Some patients are very sensitive to the effect of vasopressin. Some patients are not. But what we've shown is the addition of vasopressin to norepinephrine, so use an adjunct to norepinephrine, can decrease norepinephrine requirements. There's very little data about using vasopressin at that low dose as a solo therapy. Even though you might see that done sometimes, that's not where the data really lies. And side effects from low-dose vasopressin are going to be side effects from reabsorption of free water. So hyponatremia, and then if you were to start to administer it at too high of doses, which I would not recommend, that's when you start to see that tissue ischemia. So the VAST trial actually didn't have any effect in its primary outcome. It included about 400 patients. It was randomized controlled, and all patients had septic shock that was defined as requiring greater than or equal to 5 micrograms per minute of norepinephrine, so not too bad. But the primary outcome was 28-day mortality, and that top chart on the right actually shows you the Kaplan-Meier curve. And at 28-day mortality, there was no benefit to the addition of vasopressin or epinephrine versus norepinephrine alone. When they looked at a subgroup analysis, which the study was not powered to detect, on the bottom chart, you can see patients with less severe shock. Both their 28-day and 90-day mortality showed a benefit of potentially adding vasopressin on early. So how did this study define less severe septic shock? Well, it was patients that required less than or equal to 15 micrograms per minute of norepinephrine. So after the subgroup analysis, there were naysayers of vasopressin saying it was just, it didn't show any difference in 28 to 30-day mortality, kind of like the Angiotensin II trial. And then there were people that says, hey, there's data here that says maybe if we use it earlier on in septic shock, it might have an outcome in mortality. And there was some previous data, and there is consistently data that shows that if you add on vasopressin to norepinephrine, you require less norepinephrine milliequivalents, but with minimal side effects. So after this came out, it was adopted that we could be reasonable to consider adding on vasopressin to norepinephrine in patients that had septic shock, and maybe consider the addition of it when their dose gets to around or a little bit before 15 micrograms per minute of norepinephrine. That kind of been taken and used very widely because that low dose vasopressin has been thought to have not a lot of side effects. So I think sometimes our practice doesn't mimic, recommended use. It is one of our top expenses in the ICU because we use it as adjunct to norepinephrine in a lot of shock states, and mostly septic shock. So it costs about $300 a day to have a patient on vasopressin. So we studied that because if we have a drug on that we say may or may not be helping, the mortality data really wasn't there. It's all based off of a subgroup analysis. Do we have to have it on for the whole duration of norepinephrine? There's really not a lot of guidance what should be weaned first, whether it's norepinephrine or vasopressin. I think a lot of people agree that vasopressin seems to have less side effects than norepinephrine, and that's why the VAST trial had traditionally weaned norepinephrine off first. However, some institutions have initiated a vasopressin first wean because it has now become one of the most expensive drugs that we use and most common drugs that we use in the ICU. And what we found that if you do decide to wean vasopressin before norepinephrine, don't be surprised if your norepinephrine requirement might go up a little bit, but usually it doesn't go up that much. And if it is going to rebound or increase when you remove the vasopressin, it's usually in patients that had not been started on empiric antibiotics appropriately, or patients that still have ongoing infection. There was no difference in length of hospital stay, ICU stay, or mortality if you weaned vasopressin first. So something we've been trying to do to help with cost expenses, since the mortality data isn't there, is not to take away vasopressin in our patients, but in patients that seem to be rapidly improving, to consider taking vasopressin off before norepinephrine, which might be a little bit different than what you're used to. So recommended use by the Surviving Sepsis Guideline is that you can consider this low fixed dose rate of around 0.03 units per minute added to norepinephrine with the intent of decreasing norepinephrine equivalents. We can probably consider to discontinue vasopressin before norepinephrine in patients. I wouldn't do it if your norepinephrine requirements are high, but if you see that your norepinephrine requirements are drastically going down, your patient's improving, you might try out stopping vasopressin even before norepinephrine is off. And that kind of concludes our summary for vasopressors. And then I'm just going to touch really quick on inotropes. There's two main inotropes, Dobutamine and Milrinone. Dobutamine, brand name Dobutrex, is a synthetic inotrope that's strong beta activity. It likes beta 1 receptors and beta 2 receptors. It has preferential for beta 1, which is good because we're giving it to increase inotropy and chronotropy. So agonizing that beta receptor, if you'll remember, will increase the intracellular uptake of calcium, and that will increase cardiac contractility and chronotropy and inotropy. It does also act on beta 2 receptors, and remember, beta 2 receptors cause bronchodilation and vasodilation in the skeletal muscle. So it's known as an ionodilator. So you will see some decreased blood pressure when you start Dobutramine, but not as much as Milrinone. The end goal, of course, is to increase cardiac output through increased contractility, and it's the primary recommended agent for cardiogenic shock. And if you have concurrent cardiogenic shock in the setting of sepsis, then it's recommended to use Dobutramine as your first-line agent. Doses are in mics per kg per minute, so this is weight-based dosing, and you usually should be titrating it to a goal cardiac output or cardiac index. That would mean your patient would have either a Swan's catheter, a pulmonary artery catheter, or a non-invasive monitor like a NICOM or a Cheetah or Vigileo. Now we know that those non-invasive monitors aren't always the most accurate. So if you don't have anything to titrate your Dobutramine to, sometimes we use things like SCVO2, then you're going to be using MAP as a surrogate, but it should not be titrated by nurses. You should be using that as a clinical assessment to see if the addition of Dobutramine increased cardiac output, maybe based on bedside echo, maybe based on SCVO2, etc. The only time a nurse should be titrating Dobutramine would be if she has a reliable cardiac output monitor that she would have a goal, or he, sorry, would have a goal to. If you give super high doses of Dobutramine, you might just see some squeeze, but usually your proarrhythmic effect, because it's a strong beta 1 agonist, is out of the roof by that time. Most of the time, it's an ionodilator. It causes increased contractility, heart rate, but some vasodilation. Milrinone is brand name Primacor. It is also inotrope. It increases contractility and it increases inotropy and chronotropy, but through a different mechanism than that catecholamine receptor, that beta receptor. So it works through inhibiting phosphodiesterase, which causes increase in CAMP inside of the myocyte, which basically means you have a lot more calcium inside the myocyte than you used to. And that calcium can go bind to actin and myosin. It can increase contractility of the muscle cell. The thing about Milrinone is that it is a phosphodiesterase inhibitor, but there's more than just phosphodiesterase 3 inside of the heart. There's also, and peripherally, there's phosphodiesterase 5, and we know that when you agonize phosphodiesterase 5, you get vasodilation of your pulmonary artery and vasodilation of other peripheral vessels. So you see a lot more hypotension with Milrinone than you do with Dobutramine. Keeping in mind that they're both can cause hypotension, Milrinone probably is a more potent drug to cause hypotension than Dobutramine. It's not uncommon for the addition of Milrinone that your vasopressor requirements might have to go up concurrently, especially after you initially start Milrinone. Then they tend to level out because your cardiac output will start to increase. It is also the primary agent in cardiogenic shock. Cardiogenic shock doesn't really differentiate between Dobutramine and Milrinone, but you should look at the side effect profile of both Milrinone and Dobutramine between picking which one might be right for your patient. So this is just reiterating the mechanism of action of Milrinone. You have adrenaline cyclase that uses energy to form CAMP. CAMP is advantageous because you have increased release of calcium from the sarcoplasmic reticulum, and that calcium is what causes the direct inotropy of the myocyte. However, CAMP is broken down by phosphodiesterase 3 in the heart to AMP, which is then not effective. You need more energy to turn AMP into CAMP, but if you inhibit that phosphodiesterase 3, then you have more CAMP around longer inside of the myocyte, therefore more release of calcium from the sarcoplasmic reticulum and increased inotropy. Milrinone's dose is lower, 0.375 to 0.75. You can go higher than that, but it's also weight-based dosing. It's renally cleared, and it's got a longer half-life than dobutamine. So you might stick around longer in patients with renal failure, and you might not see the full effect for a longer period of time in patients in the ICU, which isn't always what we're looking for. And also is more causes more vasodilation than dobutamine. Now, patients that might be particularly good candidates for Milrinone are patients that would have a benefit from that vasodilation. So if you have somebody with baseline pulmonary artery hypertension, then giving them Milrinone will cause vasodilation of their pulmonary artery, because phosphodiesterase inhibition might also hit that phosphodiesterase 5, and you'll get PA dilation, which would be particularly helpful in somebody with baseline pulmonary artery hypertension or in somebody with right-sided heart failure, because you could decrease the afterload of the right heart. So you might see patients on the 6th floor especially, or patients that come in with home Milrinone pumps that have right-sided heart failure or have pulmonary artery hypertension. If you're on Milrinone for a really long time, like one of those patients that might live with a home Milrinone pump, you can see side effects like thrombocytopenia from it. However, the most common side effects are going to be usually hypotension. Another reason to choose Milrinone over dobutamine might be like somebody in a beta blocker overdose. If you need to give them direct inotrope and you wanted to avoid overcoming beta receptor agonism because you think they're all blocked, Milrinone might offer an alternative mechanism. However, when you're thinking about patients to use it in, most patients that have a cardiogenic shock because of a secondary shock state, like septic shock, we see that a lot, then the surviving sepsis guidelines actually recommend using dobutamine over Milrinone because it's just less vasodilation when you have another distributive shock state going on concurrently. So when you're thinking about vasopressors and inotropes in the ICU, you know, the goal of the addition of these would be restore organ tissue perfusion and oxygenation. So don't forget that you have to treat the underlying cause of the shock state, that the administration of vasopressors and inotropes are just to support hemodynamics until you can fix the underlying cause. Not only that, don't forget to make sure that your patient actually has fluid inside of their vasculature to pump through. So especially in a hypovolemic shock state, administration of vasopressors and inotropes without appropriate fluid resuscitation is not advised. So always remember to try to fluid resuscitate your patients if they can tolerate that before administering vasopressors or inotropes. And then when you're thinking about which one to choose, you know, ideal drug qualities would be quick onset, quick offset, easy to titrate, you know, how it's metabolized in your patient, and then adverse reaction profiles to either pick a drug that seems to be more safe in your patient population. This is a handy card, so you can probably print this slide out and put it in your pocket. But it is a summary of inotropes and vasopressors that we use at UCMC, receptors that they hit, common dosing, what hemodynamic results you have, and then what recommended shock states and side effects that you might see with them. All right, and that's all I have for you.
Hey, Jesse. That was fantastic. Thank you for doing that. Every time I learn about, like, I feel like I pick up something new every time I hear one of these talks. I will edit this a little bit and take out me talking and send it out to all the residents and host it on our website. So thanks again for taking the time to make this. I really appreciate it.
Yeah, no problem. Thanks for the opportunity.
Have a good day.
You too. Bye.